Bismillah ar-Rahman ar-Rahim. It's my pleasure and honor today to welcome and introduce Professor Wesam Ismail. Professor Wesam is a renal pathologist with over 15 years experience in interpretation of native and transplant renal biopsies. She is an assistant professor of pathology at the medical school, director of the histopathology lab of the University Hospitals of Bani Suef University, and is the owner and director of well-developed pathology lab in Cairo. She is the deputy chair of the Renal Pathology Committee of the International Society of Nephrology, and ISN Educational Ambassador for Renal Pathology. She is well known by her activities, either in education and research. I admire her work in the amyloid, especially elect amyloid. And Professor Wesam is well known by her dedication for the nephropathology. This is the links of the last two webinars about renal transplantation. She started by introduction to BAMF evolution, and then in the last week she highlighted the T-cell mediated rejection in its acute and chronic form. And today she will deliver a very hot topic in nephropathology of transplantation, which is antibody mediated rejection. This is what I did after the last webinar. In the channel, there is now a playlist under the name of Professor Wesam Ismail, and she is the second to Professor Sobh to have a playlist in our virtual academy carrying the name. So Professor Wesam Ismail meetings nephropathology from A to Z, and I restrict the links to the last 13 webinars. So if you go to this playlist link, you will find all the 13 meetings in one click. And I'm going to share this this playlist to the Facebook and tomorrow, inshallah.
And emails as well, please.
Yes, okay. Today, Professor Wesam will hit a very important topic in transplant pathology, which is very exciting. A lot of mysteries are there, and it is well known now that antibody mediated rejection is one of the most important leading causes of graft failure. Today, she will discuss it, and it's the evolution in the current BAMF 2019, plus its a differential diagnosis. So it is my honor and pleasure to welcome Professor Wesam Ismail. Also, I would like to welcome Professor Ahmed Halawa and all the candidates of Liverpool Master of Transplantation, and the mic is to Professor Halawa.
Thank you, Professor. Thank you to Professor Wesam Ismail for this help and support. Actually, we really enjoyed the lecture. She made the pathology a bit easy than it should be. But however, I know it's quite a difficult task because you rely on just a tiny bit of the kidney to make a diagnosis, and to treatment, will be based on her decision. I'm very, very grateful to your contribution, and I welcome all colleagues from University of Liverpool. Back to you, Professor.
Professor Wesam, please share your slides.
Okay, good evening, everyone. Thank you very much, Dr. Hussein. And this is a great surprise and really a great honor that you put me second to our great Professor Muhammad Sobh, and for the link and for all your efforts to make this educational activity first available, because you've been the dynamo behind it, and second for all the organization and the effort you put into it. Okay, before we start today, we'd like all the attendees who would have questions to please write the questions in the chat at the end of the talk, and please, for the other attendees, to refrain from answering the questions. So who has a question who's directed to the speaker or to one of the moderators or the professors we have within the session, so please write it. And please, nobody else answers it, so we can go through all the questions systematically and answer them one by one when we are done. Okay, today is the second or third session in transplant pathology, and I'm going to discuss the pathology of antibody-mediated rejection to the best of my knowledge. Because when we come to discuss antibody-mediated renal allograft rejection, we know that we have some facts which are known. We have a lot of facts which are unknowns, and we have more facts which are a great source of confusions. So I'll go through today a terminology, types, histology, detection, in an effort, hopefully, to try to clear some of the unknowns and confusions and stress on what we already know. In 2019, this is what antibody-mediated rejection looks like. So we have more or less the same categories. We didn't change much since 2017 or even 15. And as you can see, we have active antibody-mediated rejection with all of these types. Then we have the other category, type, which is chronic active ABMR. All of these are not new. We had the category since the beginning and still existing, where we have C4d staining without evidence of rejection. But we have a new entity actually into the classification, which was not included in the previous ones, which is chronic inactive ABMR. And it's really a modification of terminology rather than a different or a new type. And again, to remind you with the scores, when we come to consider what are the diagnostic scores we use within the classification for ABMR lesions, we use the G score, glomerulitis, peritubular capillaritis score, C4d. We use the CV score for transplant arteriopathy, CG for transplant glomerulopathy, PTCML if electron microscopy is available. And these are basically the scores which we use to establish a diagnosis related to antibody-mediated rejection. As I've discussed before, and I'm stressing again, these scores are not by themselves sufficient to reach the various band of diagnostic categories, and that at the end of the day, we integrate the clinical, the serological, and the rest of the morphological features and the rest of the scores, because we do score everything else to get to a diagnosis. But in order to make it simpler for you, these are the scores which are mainly related to the diagnosis of what we consider antibody-mediated rejection. Let's forget about BANF for now. And let me start by saying, what do we actually understand under the term antibody-mediated renal allograft rejection? How much do we know? We know that it's a significant and often severe form of allograft rejection that is unresponsive to treatment with standard immunosuppressive medications. We know that it's considered to be a major cause of renal allograft loss, if not the major cause of renal allograft loss. And since the dark ages for antibodies back in the 1990s, where all what we knew about antibody-mediated rejection was hyperacute rejection, which occurs on table, as most of you know, and that now we rarely see, where you have only neutrophils in peritubular capillaries and glomeruli. And the other type, which we used to describe as accelerated acute ABMR, which used to occur within the first 48 hours post-transplant. This is all what we knew about antibodies and antibody-mediated rejection. But we have moved a long way since these dark ages, all through the years, by the discovery of the C4d and the DSA. And since the detection of this, we have been able to identify more lesions related to antibody-mediated rejection. We've been able to understand the mechanism and the pathogenesis which leads to this injury to the allografts, as well as that we have improved a lot in our methods of detection of donor-specific antibodies. However, through this through this journey, we've come to get a bit confused between all what we've discovered in relation to antibody-mediated rejection. So is this an early form of rejection or late? Does it involve cells, or do we have lesions which are mainly endothelial? Is it related to DSA or C4d, and what's their story? Is it an acute or a chronic lesion? Is it an active or an inactive lesion? All of these terms, all of these terminologies are related to what we call antibody mediated rejection. And I'm hoping that tonight I'm going to tell you the story of all of these elements in it. And it's a story, and I want you to encompass the fact that this is what we're going to do tonight in order to understand what do we really mean by an antibody mediated injury to the kidney. In order to diagnose an antibody mediated rejection, we have several arms we need to walk through or comply to in order to say that we have an antibody mediated rejection. We need, on one hand, to have evidence of tissue injury, and this is seen in the biopsy. We need plus or minus clinical impairment for the patient, and we need evidence of antibodies to correlate this tissue injury to the presence of antibodies. And evidence of antibodies is in the biopsy and or serology. So again, in order to say that the patient has antibody-mediated rejection, we need to first identify the injury in the biopsy and then be able to relate this injury to the presence of current antibody activity. And how do we do this? We do this by findings in the biopsy plus or minus serology. It depends on the different situations. So let us start by evidence of tissue injury. What is the evidence of tissue injury, or what is the types of tissue injury that we consider that they could be related to antibodies? According to these types of injury, these are the types of antibody-mediated rejection within the Banff classification. We don't have an acute type. The word active replaced acute. We don't use acute anymore to avoid confusion, and I'm going to say why later on. So we have active antibody-mediated rejection. So we have current activity, which usually presents with an acute presentation. Then we have chronic active antibody-mediated rejection. We have chronic inactive antibody-mediated rejection, and we have the C4d deposits without evidence of rejection. So we have 4 types which are related to antibody-mediated rejection within the classification. The first thing we need to know that these are types, not grades. This is not like T-cell mediated rejection. We don't have grades of the rejection. We don't have classes of severity. We only have types of rejection, but we have absolutely no evidence till today which tells us which type is going to be more severe than the other type. Which type of tissue injury shall we consider more aggressive, except of course for the known prognostic factors that we already know. But these are types, so they are not classes nor grades. The second point we need to know is that these types can occur anytime post-transplant, and hence the drop of the word acute. So they can occur early, they can occur late post-transplant. I want you to look at antibodies the same way that we look at autoimmune diseases. Take lupus, for example. Now, lupus is an antibody-mediated disease, by the way. We have antibodies. As long as you stop looking at antibody-mediated rejection as a single episode or at rejection processes in general, and that you start looking at it as a disease, which sometimes can evolve into a chronic disease with flares of activity and residual tissue injury, which results in chronic effect, the more you're going to understand the concept of rejection. So if we consider that we have at one end a maximum activity, which usually occurs early in transplantation, and however, this activity can also occur late in transplant. Yes, with at least incidence compared to early post-transplant, but can occur up to 10 years post-transplant. And at the other end, we have, this is usually early, this is the acute decline, this is the process where we have infiltration and proliferation and a lot of cells and so on. And on the other end of the scale, we have the chronic changes, the sclerosed end. These changes are mainly sclerosing and sclerosed, and they occur late, and this is what we call chronic. But these chronic changes can also start as early as 2 weeks post-transplant. So at one end, you have the very acute active changes, and at the other end, you have the very chronic inactive changes. Yes, they are related to time, of course, but they can both occur very early or very late. What about this orange triangle? This orange triangle where you have these patients who are overlapping between the active stage and they already started the chronicity. And this is the term chronic active. This is what we call a chronic active rejection. And hence, when we come to consider when can we have an acute allograft rejection in the process or in the time span of a transplant, any time, at any stage post-transplant, because activity can occur anytime. It can either be purely active condition because you still don't have any chronic changes, or this activity can overlap over a residual chronic injury. Okay, let's start with the criteria of active antibody-mediated rejection. Now, one of the first morphological, I'm sorry, the picture is a bit hazy. Well, this is an acute tubular injury. So an entity in the morphological evidence of acute tissue injury related to antibodies is the presence of acute tubular injury in the absence of any other apparent cause. What is any other apparent cause? Means that if I don't have any other apparent cause for this acute tubular injury. Of course, this is not enough. Usually preferably this acute tubular injury have some form of minimal inflammation. What is the minimal inflammation? That we have neutrophils, at least more than one neutrophil per glomerulus, or more than 2 neutrophils in peritubular capillaries per field. We consider neutrophils early sensitive cells for antibodies. Look at this. This is a nice glomerulus which have 4 neutrophils per capillary. It has also another neutrophil here and another one here. So this is glomerulitis. And this patient had acute tubular injury and just these few neutrophils here. So this is what you can call minimal inflammation. What is the main differential diagnosis of this? Of course, the main differential diagnosis is CNI-induced tubulopathy, is drug toxicity. Now, CNI-induced tubulopathy is what was defined as isometric vacuolization of proximal tubular cytoplasm. And this happens due that you get dilated endoplasmic reticulum. This lesion, or CNI-induced acute tubular injury, is induced by both cyclosporin and tacrolimus equally, and both gives identical histological changes. And the toxic effects are not always dose dependent. Remember this, because we do have some idiosyncrasy in the process. And these changes affects both native kidneys and renal allografts, by the way. So patients who are on cyclosporin for treatments of podocytopathies are also liable to get a CNI-induced tubulopathy. Its differential diagnosis include other drugs which can cause the same type of tubulopathy, like drugs given in mannitol or dextran solutions. IVIG can cause the same thing, hyperimmune globulin because it's rich in sucrose, and ischemia. So you can actually have acute tubular injury either related to ischemic change, hypoperfusion of the kidney for any reason, CNI-induced, and at the end of the list, it could be antibodies. And the isometric vacuolization you all read about in papers and in textbooks, that this is the diagnostic hallmark for CNI tubulopathy, is helpful when it's there, but it's rare and it's not a must for diagnosis at all. This is what we call isometric vacuolation. You get equal, more or less equal vacuolation of the tubules. And this is fine isometric vacuolations, and this is basically what you usually get in an acute tubular injury. So the differential diagnosis is always open for it. Sometimes with CNI, you get classification, and this helps to pinpoint that this is a CNI-induced toxicity. Into IVIG, as I said, causes the same picture, and you get again the same isometric vacuolation, which is basically hydropic degeneration of the tubular epithelium, as you can see here within the tubules. This patient injury was caused by IVIG, and this is an ischemic insult, and it still looks the same. So The first lesion, which has been related to antibody-mediated rejection, has a wide differential diagnosis. And bear in mind, as we said, that lesions have to have evidence of antibodies. So the acute tubular injury would only be related to ABMR if we have very strong evidence that we have antibody-mediated injury. If we have injury with causes like myeloma, like cause nephropathy, this is usually caused by mTOR inhibitors, and we've seen it not commonly, but you do see it occasionally in patients who are on RAPA or other types of mTOR. The second criteria for acute tissue injury related to antibodies is what we call microvascular inflammation. Now, microvascular inflammation, again, is to be considered related to antibody-mediated rejection only in the absence of recurrent or de novo glomerulitis. So here, the differential diagnosis would include that we don't have a glomerulonephritis going on. What is microvascular inflammation? The term microvascular inflammation came up in 2013 and encompasses two compartments of the kidney, which represents the microvasculature of the kidney, meaning capillaries. So since we're discussing capillaries, so this is related to glomerulitis, inflammation in the glomeruli, and peritubular capillaritis, inflammation in peritubular capillaries. So the MVI score is basically the G score, which scores the glomerulitis, and the PTC score, which scores the peritubular capillaritis. Let us start with transplant glomerulitis. I want to tell you that this is one of the least reproducible lesions in Banff scoring, meaning that it has a poor reproducibility between pathologists. G0 and G3 are reproducible. So everybody can agree if there is no glomerulitis or if you have severe glomerulitis. But between G1 and G2, the reproducibility is really poor. It's defined by having occlusive lymphohistiocytic cells within the capillary, but not only the presence of cells, but you also need evidence of endothelial cell swelling or endothelial cell activation. Usually these glomerular capillaries are dilated, but not a must, and you don't have any changes in the glomerular basement membrane, no diagnostic immune complexes by IF, and these patients usually do not have more than minimal hematuria and proteinuria, except of course in advanced cases, some patients can get up to nephrotic level. Transplant glomerulitis, although is considered one of the main lesions related to antibody-mediated rejection, can also occur in T-cell mediated rejection. So in cases where you can see glomerulitis, but you have C4d-negative and you have no evidence of detectable DSA, so you have no evidence of any antibodies, so this is going to be a form of T-cell mediated rejection. It can also be a form of mixed rejection, would have a mixed T-cell and antibody-mediated rejection. Usually the commonest, it's pure antibody-mediated glomerular injury. And if we're stuck, we usually can detect by the type of cells you can see within the glomerular infiltrate. If it's dominantly CD3, then this is probably T-cell mediated. While if it's dominantly CD68, which is a marker of macrophages, so this is probably antibody mediated. So in antibody mediated rejection, you get less T lymphocytes and more macrophages within the glomerular injury. The CD68 or the presence of macrophages is gaining more and more importance in the glomeruli, to the extent that we probably are going to score, or that we cannot swear that we don't have glomerulitis except if we do CD68 score. So we're expecting that in the near future, we're going to have the CD68 staining as a must also for the evaluation of glomerulitis, of the presence of glomerulitis or glomerular inflammation per se. This is an easy marker. It's present in all pathology labs. It's not something sophisticated at all, and it's been in the market for years and years. So it's accessible for everyone. This is not something new or difficult to get, and it's really a helpful marker. Again, this is an example of glomerulitis where you get these intracapillary leukocytes as well as endothelial swelling. So not only the presence of the inflammatory cells, you need to have other evidence that these inflammatory cells are aggressive by endothelial swelling. This is glomerulitis. See dilated, glomerular, capillary, lymphocytes. These are swollen endothelial cells, and this is typically what we call a classic lesion of glomerulitis. And glomerulitis can occur by mononuclear cells and or neutrophils. There are no specific cells for these lesions. Sometimes you get to see a more severe form of glomerulitis, or you start to see that the glomeruli starts to be congested together with the presence of these glomerulitis, and you start to get fragmented red blood cells. And with these fragmented red blood cells, you start to get this fibrin, you start to have a bit of early occlusion, really serious occlusion of the capillary lumina. So in this stage, you are actually the injury is getting to be more severe, and you're entering into what we would consider thrombotic microangiopathy, the third feature of what we consider related to antibody-mediated rejection. So thrombotic microangiopathy, one of its characters is also glomerulitis. So sometimes in the same biopsy, you can see the span of glomerulitis up to the more severe affection in the glomeruli in one or two glomeruli. But we always judge on the most dominant feature or the most severe affection. So in this case, it's going to be classified as a TMA. TMA can also occur only in arterioles. As you can see, this is an arteriole with a fibrin thrombus of this red. This is a trichrome stain. And you can see also the extent of endothelial injury and the fibrin thrombus. And this arteriole and a single arteriole would be enough to diagnose thrombotic microangiopathy. If this TMA has evidence of antibodies, then this is antibody-mediated injury. What if it does not have evidence of antibodies? Again, this is extensive thrombotic microangiopathy. Sometimes, as I've mentioned before, when we discuss TMA, you don't have to have thrombi. And as you can see here, you have extensive congestion and red cell fragmentation within the glomeruli. Here you have thrombosis and already cortical necrosis surrounding this thrombosed glomerulus. So all these are a spectrum of thrombotic microangiopathy. Now, thrombotic microangiopathy in renal transplants can occur in relation to antibody-mediated rejection, can also be drug-induced. And please, it's induced by CNI, and it's induced both the same by cyclosporin and tacrolimus. I know years and years back, when tacrolimus was very first introduced into the field, one of its main advantage points where they were promoting the drug with was that it has at least less incidence of thrombotic microangiopathy than cyclosporin. Of course, this turned to be completely untrue. Both drugs have the same side effects with the same incidences. So tacrolimus causes thrombotic microangiopathy as much as cyclosporin causes thrombotic microangiopathy. mTORs, also there have been few reports also reporting TMA that could be related to mTOR. I have never seen one. All the drug-induced ones we've seen were related to CNI. And as I said, antibody-mediated rejection, but we also, within this lesion, have to consider recurrent disease, whether this is an atypical HUS, whether the patient has antiphospholipid syndrome, and accelerated phase hypertension. Please don't forget it, because these patients can still develop hypertension from the CNI and the steroids and can still get into an accelerated phase hypertension. So this would be the differential diagnosis of TMA in renal transplants. But as we're discussing antibody-mediated rejection, thrombotic microangiopathy occurs as one of the major features of active antibody-mediated rejection. So this is our glomerulus with glomerulitis. As you can see this very nice neutrophil with with multi-lobed nucleus, as you can see, dilated capillary, swollen endothelial cells, but this basement membrane is not very thin. This basement membrane is starting to get thick and vacuolated and slightly duplicated, as you can see here. So what is happening? What is happening is that this is a continuous injury. This patient had persistent inflammation, and this persistent inflammation will lead to changes and alterations of the glomerular basement membrane. And mainly this alteration of the glomerular basement membrane is in the form of glomerular basement membrane duplication. So as you can see in this glomerulus, we have duplicated GBM here and here, and we still have leukocytes and endothelial swelling. We still have glomerulitis, and sometimes even the glomerulitis is more than the presence of the basement membrane duplication. Look at this at a higher power. You can see the duplicated glomerular basement membrane very nicely, and you can see the glomerulitis also very nicely. These are the lymphocytes, these are the endothelial cells. Again, the duplicated glomerular basement membranes, look here, peripheral duplication of the GBM, and this is what we call transplant glomerulopathy. And transplant glomerulopathy is one of the features of chronic active or inactive antibody-mediated rejection. So transplant glomerulopathy is actually a consequence of transplant glomerulitis. So we start with the inflammation. Whether this inflammation or the process or the endothelial insult gets severe enough that we can develop a thrombotic microangiopathy or not, in all cases, by time evolution of the persistence, this requires the persistence of the injury. With the persistence of the injury, these active changes will start to cause chronic changes, and these chronic changes in the glomeruli is what we call transplant glomerulopathy, and hence we consider it one of the tissue evidence which is related to chronic active or inactive antibody-mediated injury. Look here, this glomerulus, for example, have extensive swelling and vacuolation of its glomerular basement membranes. You have one here and another one here. Transplant glomerulopathy can be seen anytime after transplant. And there was this brilliant study by Nankivil back in 2011, where he showed that the early ultrastructural changes they've detected, the early ultrastructural changes by EM of transplant glomerulopathy as early as 2 weeks post-transplant in their patients. This is the Australian group. And Nankivil, by the way, is a transplant surgeon. And as I said, this is a lesion which is induced by transplant glomerulitis. Up to 50% of these cases are C4d positive, means that they are related to antibodies, and they are usually associated with chronic vascular changes. Patients can have mild hematuria. Their proteinuria is quite variable, and the range is very varied. They start from subnephrotic proteinuria up to nephrotic. I once had a patient who had 20 grams proteinuria, and we've done EM, and she had absolutely nothing except TG, transplant glomerulopathy. It's related to poor long-term graft survival, and its differential diagnosis is chronic thrombotic microangiopathy. And it's not really a differential diagnosis because it's more or less the same lesion. As you can see here by electron microscopy, this is one basement membrane, the endothelial cells, and this is the other new basement membranes. So you can identify clearly and sharply that you have a duplicated glomerular basement membrane and you have significant endothelial cell injury, no evidence of immune complexes anywhere within the glomerular basement membrane. This is TG. This is from the study of Nankivil, where they have noticed the very early changes of transplant glomerulopathy, which has been right now re-identified, and the new definitions or very specific definitions for the electron microscopic findings of transplant glomerulopathy are now being incorporated into BANF through the BANF working group of electron microscopy, and they started to define the early lesions of transplant glomerulopathy by that this is subendothelial widening of the basement membrane. This is the very early lesion of TG. So this is basically this is one of the major tasks of the BANF working group for EM. And this is what's going on with the EM changes in relation to BANF classification, in relation to transplant glomerulopathy. So as you can see, transplant glomerulopathy is a descriptive term. It's not a diagnosis per se. So we don't diagnose patients by saying transplant glomerulopathy. We have to say what we think this transplant glomerulopathy is related to. Is this transplant glomerulopathy related to chronic active rejection? And which type of rejection is it? Do we think this is antibody mediated? Do we think it's mixed cell and antibody mediated, or is it pure T cell mediated? If the glomerulitis, which induced the transplant glomerulopathy, is T cell mediated, is this a result? Is this just the chronic TMA? This patient had history of thrombotic microangiopathy, which was induced by CNI, and it turned to be chronic because these patients are still on CNI. So is this just a chronic TMA? We have to exclude recurrent disease in this patient. It's not MPGN, it's not Hep C related, it's not a KS and cryo, and it's not a typical, sorry, this is a typo here, a typical HUS. It also has been reported in transplantation of size mismatched kidneys. This is not a common scenario, of course, so not to be very much considered. Okay, but of course, the main consideration for transplant glomerulopathy would be rejection. What do we mean by active and inactive? And when can we consider that this is just a chronic TMA? The whole issue is that this is what I'm telling you. It's a story. The story started by transplant glomerulitis, and if this inflammation, or by thrombotic microangiopathy, and if this injury is rejection induced, is induced by antibodies, then the antibodies did not go anywhere. The antibodies are still there, and they are still working on the kidney, and they are still causing this glomerular injury. So you still see the effects. So this is what we call active. As all the examples I have shown you, you have the basement membrane duplication, but you can have early thrombi and you still have glomerulitis. While if it was a story and it ended like a TMA insult, which was induced by CNI, then all what you're going to have is just the basement membrane duplication. Can I swear? No. If I don't know the history of the patient, then I don't know. All what I know is that this is an active form of TG. So these ones are 99% related to rejection, while these inactive ones could be related to rejection or could be related to that this is just a chronic TMA. The other part of microvascular inflammation, and the more common one we encounter in biopsy than glomerulitis, is peritubular capillaritis. Again, this is a lymphohistocytic cell elements which are present in peritubular capillaries of the cortex. We do look at the medulla, and we do consider that we have peritubular capillaritis in the medulla, but we don't score in the medulla. We only score in the cortex. And the score in peritubular capillaritis is very important. Peritubular capillaritis can be caused both by lymphocytes and neutrophils. So this is a tubule, this is a peritubular capillary, and it's full of neutrophils. And there is nothing else. As you can see, there are no tubularitis, no inflammation in the interstitium, there is absolutely nothing. Also, it can be caused by mononuclear cells, by eosinophils, plasma cells, whatever. So any type of cells in peritubular capillaries. How do we score? We count the cells, and we take with the maximum number of cells. That means that we almost score all the peritubular capillaries in the biopsy. Same is for the glomeruli. We also count the number of cells, the number of glomeruli which has glomerulitis. While in peritubular capillaries, we count the cells. So this is 1, 2, 3, 4, 5, 6, 7, and this is how we score. Score 1 is up to 3 cells per peritubular capillaries, 2 is from 3 to 10, and PTC 3 is more than 10. So you can easily see that this one is a PTC 3. You have more than 10 inflammatory cells in a single peritubular capillary. This is what peritubular capillaritis look like. Again, this is a PR stain, and you can see tubules. The nice tubules, there is absolutely nothing in them, no tubulitis and anything. All this inflammation is not in the interstitium, it's inside the peritubular capillaries. So all of these prominent cells are in the PTC. This is tubulitis, and this is peritubular capillaries. And for pathologists, be careful not to mix an extensive tubulitis with a peritubular capillary, because you can mistake this for that, and then you can score a higher score for PTC. Again, PTC with a lot of nice neutrophils, as you can see, and congestion and red cell fragmentation. These are the tubules. And this is C4d, and with C4d, of course, it delines, as we're going to discuss in C4d, the peritubular capillaries very nicely, and you can see the peritubular capillaritis much easier. Here are the tubules, and this is the peritubular capillaries, which are C4d positive. Okay, do we have a differential diagnosis for this lesion, or is it specific? Unfortunately, this is one of the least specific lesions that we can use for antibody-mediated rejection. But the more important differential diagnosis is, and we have alluded to this point before, is that when you get all the peritubular capillaries engorged actually with neutrophils, like in this biopsy, you see all of these are neutrophils. Here also is neutrophils. Here are neutrophils. This is one field. This is the other field of the biopsy. Again, extensive neutrophilic infiltrate in the peritubular capillaries, but also neutrophilic tubulitis. So be very careful that not always it's the neutrophils which are in the, it's not always neutrophils means antibody-mediated rejection. If you have neutrophilic tubulitis, then you need to consider infectious tubulointerstitial nephritis or pyelonephritis. As I said, we have limited specificity of microvascular inflammation. As you can see, microvascular inflammation can be seen in cases with no rejection, in cases with borderline rejection, and up to 70% of cases with T-cell mediated rejection, whether for glomerulitis or peritubular capillaritis. It's not related to the C4d positivity, whether it's negative or positive. And we also, this lesion is not pathognomonic for antibody rejection because we see it in many tubular interstitial diseases. We see it a lot in lupus. It's always present in lupus nephritis. You can see it in cryoglobulinemia. Actually, in any other antibody-mediated disease, you will see a lot of peritubular capillaritis. Again, with persistent inflammation in the peritubular capillaries, what's going to happen? What's going to happen is that you're going to get thickening of the capillary basement membrane, what we call capillary basement membrane multi-layering or peritubular capillary basement membrane multi-layering, which is a feature of chronic active or inactive antibody-mediated rejection. This is what we call peritubular capillary basement membrane multi-layering, which is scored by the PTCML score, and it requires more than 5 layers of the peritubular capillaries. This is a pure electron microscopy findings. It's not like the transplant glomerulopathy where you can see it on light microscopy. No, this one requires EM in order to be able to score it or see it. Again, this is basement membrane multi-layering and the PTCML score in the peritubular capillaries, and if you count them, you will see that there are more than 5 layers. This is considered related or significantly related to chronic active antibody-mediated rejection. The latest included criteria for acute antibody-mediated or for active antibody-mediated rejection is antral arteritis. We've discussed this extensively when we talked about T-cell mediated rejection, but I just want to make it clear again that we've always considered type 3 could be related to antibody-mediated or T-cell mediated, which is the transmural one with the V3 and the extensive fibrinoid necrosis. However, what is new is that we can consider V1 or V2 also related to active antibody-mediated rejection. I've shown you this study before, and it's because of this study and other studies that antral arteritis, any V more than 0, have been included in BANF 2015 as one of the features for active antibody-mediated rejection. I want you to remember that this lesion is still a T-cell mediated lesion, and that V lesions are very, very rarely considered to be pure antibody mediated. So if you have a V1 or a V2, these lesions are still mainly T-cell mediated in more than 95% of cases. And usually if they are present, it's going to be a mixed form of rejection rather than pure ABMR. But there was enough evidence to convince the Banff group that these lesions could represent in a rare scenario by being only pure ABMR. And following the same story, persistent antibody arteritis is going to lead to transplant arteriopathy, which is one of the features of chronic active antibody-mediated rejection. In 2007, chronic allograft or transplant arteriopathy, which was only included in relation to T-cell mediated, but in 2015, it was changed that lesions of transplant arteriopathy may represent chronic active ABMR as well as T-cell mediated, and that the latter may also be manifest in the tubular interstitial compartment. So transplant arteriopathy has also been included as a chronic active lesion in antibody-mediated rejection, defined as, and I know we've also discussed this last time in T-cell mediated, that it's defined as arterial entemal fibrosis of new onset, but you need to exclude other causes. The same scenario with the active lesion, with entemal arteritis. Here, you have to have that there is no prior history of T-cell mediated rejection. How are we going to know this? It's said that if we have leukocytes within the sclerotic enema, like here, if you have lymphocytes, and like here, that this is going to favor more an ABMR, but of course, this is not a must, and it's not required. So this is a lesion of, again, exclusion. So to sum up, lesions which are considered evidence of tissue injury related to active antibody-mediated rejection are transplant glomerulitis, thrombotic microangiopathy, microvascular inflammation, which is peritubular capillaritis, and entemal arteritis. These are the lesions that we can consider related to active antibody-mediated rejection, while those related to chronic active rejection are actually the chronic counterpart of these lesions, which is transplant glomerulitis, transplant arteriopathy, and peritubular capillary basement membrane multi-layer. So this is the evidence of injury, or this is the lesions which are related to antibodies. And as I've been saying, and as you're seeing, these lesions can overlap with T-cell mediated rejection as well as with other diseases. And hence, none of these lesions can be considered diagnostic except if we have evidence of current circulating antibodies. So these lesions need to be related to this evidence of current circulating antibodies. What is this evidence? This evidence in the biopsy, and this is the one I'm going to talk about, is microvascular inflammation and C4d, and I'll allude very briefly to the molecular microscope. Let's start with C4d. I know that most of you knows what is C4d, but I also know that a good percentage have grown into the field with just the term C4d, which is there, and they don't really know what is C4d. Now, C4d was first described by Fucht in 2000, first paper was in 2003, and C4d was a major breakthrough, and it's because of the discovery of C4d that we know all what we know about antibody-mediated rejection now. What did this marker do? This marker provided the missing link we needed to have to detect antibodies. It provided a unique immunohistological marker for antibody-mediated alloreactivity. You see what happens with antibodies is that you get antibody reactions on endothelial cells, and then you have activation of cytokines, a lot of factors, macrophages, and a lot of cells, but all of this gets washed away with the blood stream. And you don't get to know whether you really had antibodies interacting with this endothelial cell or not. What C4d done and C3 was that it forms internal protected thioester groups with the endothelial cells. So it was able to give us a footprint of the antibodies on these cells. So we were able to detect it. But these bonds are transient. So it forms transient covalent bonds with thioester groups on the endothelial cell surfaces and matrix components. So it gave us a stable molecule which we can look at and know that we had antibody reaction in this area. So this is basically what C4d is all about. Not only the C4d, C3d also, but it's less consistent and much less specific than C4d. So this is why it did not gain the acceptance, and it was not validated all through the rest of the studies. But C3d also can form these transient covalent bonds in some cases. In 2013, because of the importance of C4d, we needed to define what the pattern of C4d staining. And I've also discussed this the first time. And I said that basically we stain C4d by two techniques, by immunofluorescence and by immunohistochemistry. And that since 2013, any C4d staining by immunohistochemistry on paraffin tissue in cortex or medulla is positive. Now, this is one of the rare scenarios where we use medulla. So if I have only medulla in the biopsy and it's C4d positive, this is C4d positivity. This is evidence of the presence of antibodies. So we score everything in the cortex, but C4d can be scored either in cortex or medulla. The score, because this is also causes a lot of confusion, the C4d 1, 2, and 3, as you can see, is related to the surface area where we have C4d in the biopsy. And this score is mainly to compensate in the difference between the sensitivity of both techniques. So its interpretation should be adjusted to the technique we use. It's not related to the severity. It does not mean that the patient has less DSA because his score is C4d 1. Of course, if it's more abundant, then you have a more significant injury. That makes sense. But you cannot really say that he has just a score C4d 1, so this is a mild form of rejection. It doesn't go this way. The score is basically for the evaluation of the staining. And this is what we mean by C4d 1, a single peritubular capillary, which can be very difficult to find, by the way. So you have all the peritubular capillaries, surrounding peritubular capillaries negative, and this is a single peritubular capillary. This is what we consider positive for C4d staining, circumferential, linear, non-granular staining of the C4d. See this nice, clean, crisp staining of the peritubular capillaries, and this is positive for antibody mediated. So it's the C4d staining in the peritubular capillaries, which is specific for antibody mediated, not anywhere else in the biopsy. Again, this is C4d, and you can see the peritubular capillaritis and the C4d outlining all the peritubular capillaries. Sometimes when you get a lot of C4d and there is overflowing of the antibodies injury all through the endothelium, you get it also in the glomeruli, as you can see here. So also the glomerular endothelium shows C4d, and sometimes also the vascular, even the endothelium of the arteries. You have some sort of overflow of the antibodies everywhere on all the endothelial surfaces in the kidney. So you can detect C4d everywhere. But if it's only glomerular, I cannot consider the biopsy C4d positive. What is positive, what's transplant specific, is on the peritubular capillaries. With the introduction of endothelial transcripts, or what we call INDATs, or with the molecular studies into the transplant field, we've started to realize that not all antibody-mediated rejections are C4d positive, or that not in all of antibody, let me be more clear, not in all biopsies of antibody-mediated rejection, you can detect the C4d. So before this era, we considered only antibody-mediated rejection when the C4d is positive. But the work of Philip Halloran group and Banosis with the index, with the endothelial transcripts, have shown that there are biopsies where you have that transcripts related to antibody-mediated rejection, endothelial expressions of genes and mRNA, which are related to rejection, but these biopsies were not C4d positive. And so we started to know that we can have a C4d negative form of antibody-mediated rejection. This was also strengthened, this is back then since 2006, this was strengthened by experimental evidence that we can have C4d negative ABMR, where these MHC incompatible rats have developed transplant glomerulopathy, but they did not have any C4d positivity within their biopsies. In 2007, this work by Alexander Lupi, they have looked at their kidney transplant recipients who had already preformed donor-specific antibodies. So these are pre-sensitized patients. We know that these patients has antibodies. And they have looked at the protocol biopsies, their protocol biopsies at 3 months and 1 year post-transplant. They had, out of the 157, 90 biopsies which were C4d positive. And in these 90 biopsies, they had microvascular inflammation in almost 99% of them, 84 out of the 90, while only 6 did not have microvascular inflammation, have any evidence of glomerulitis or peritubular capillaritis. On the other hand, the 67 biopsies which were C4d negative, almost 50% of them had peritubular capillaritis and glomerulitis. So we know that these patients have ABMR. We know that they have DSA. We know that these patients have pathological DSA. They had already pre-existing DSA. And these are protocol biopsies. So you can see that patients they had their preformed DSA, the protocol biopsies had almost 90, around 60% of them were C4d positive, and this related to microvascular inflammation. While these ones with no C4d positivity had around 50% microvascular inflammation. What did this lead to? When they continued their study, they have shown that subclinical progressive microcirculation injury had been ongoing in these pre-sensitized patients despite that they were C4d negative, because without C4d negativity, without C4d positivity, you could not call them antibody mediated, but still they had ongoing injury of transplant glomerulopathy. They had CG score more than 0. They had significant IFTA more than 0, and their GFR at 1 year was affected. This was followed by the study again by Benussis from Halloran group, from the Alberta group, which have shown that DSA positivity was very much correlated to the microvascular inflammation score. What is the microvascular inflammation score? Again, the glomerulitis and the peritubular capillaritis score. So the more glomerulitis and peritubular capillaritis you have, the more circulating DSA you have, as you can see here. So if G plus PTC 0, 20% out of 220 patients were only DSA positive. On the other hand, if G and PTC equals 5, the maximum score is 6. If G and peritubular capillaritis score equals 5, 89% of these 9 patients were DSA positive. So this brought up a very important issue, is that we use microvascular inflammation as evidence of tissue injury, which is related to antibodies. But with these studies, we can also use microvascular inflammation as evidence of presence of antibodies, but with a minimal score. Again, I've said that when we see microvascular inflammation, meaning that we see inflammation in the glomeruli or peritubular capillaries, this means that we probably have an antibody-mediated injury. And we have agreed that I need to correlate this antibody-mediated injury to evidence of antibodies. My strongest evidence of presence of antibodies and DSA is C4d. But what if the C4d is negative? Then I need something else instead of the C4d. Studies have shown that we can use the score of the MVI, the G and the PTC together as evidence of current antibodies, but with a score of 2 and more. And this is only in cases where we don't have associated T-cell mediated rejection. Why is that? Because normally if you have a T-cell mediated rejection, you have peritubular capillaritis. If you have inflammation in the interstitium, you're going to have inflammation in the peritubular capillaries. So not to overdiagnose microvascular inflammation, we have very strict criteria. To use MVI as evidence of antibodies, we need to have a score of 2 or more in the absence of T-cell mediated rejection. If we have T-cell mediated rejection, then we need a G score of 1 at least. Only peritubular capillaritis is not going to work. So in BAMF 2013, we have already included C4d-negative antibody-mediated rejection, and we have concluded that we can diagnose both active and chronic active antibody-mediated rejection in the absence of C4d deposits. However, in the absence of C4d, and I'm stressing for the zillion time, you have to have additional evidence of current or recent antibody interaction with the vascular endothelium. What is this evidence? This evidence is the MVI score of 2 or more. Why would the C4d would be negative? We know that it's positive because we have complement activation, we have complement-dependent cell injury, we activate the endothelium, and we get recruitment and activation of leukocytes. So why could it be negative? Before considering that this is non-complement fixing antibodies, or that these are non-HLA antibodies, consider other more common scenarios, which would make sense because the others are really rare scenarios. Is it too low that we cannot detect it by the current methods? Did you give your patient anti-rejection treatment before the biopsy, which happens commonly? This will make the C4d go away. Is it the focal deposit of the C4d? So this is a sampling error. Was it there, but it's not there anymore? So this is a remnant of previously active ABMR. C4d is like a rain shower. It comes and goes with the activity of the antibodies and the DSA. So you might detect it in one biopsy, and in the following biopsy, it might not be there, or vice versa. The first biopsy could be C4d negative, and a follow-up biopsy 1 week later could be C4d positive. As long as we understand this, then you need to know that C4d can change from negative to positive or from positive to negative because it can go away, and that we have to consider sampling errors. We have to consider that we had that we gave anti-rejection treatment before considering that this is non-HLA induced or non-complement fixing antibodies, because at the end of the day, we don't really know the pathogenesis of these lesions. After this, in 2013, a lot of people started saying that, so why are we doing C4d if it can be negative? And that if we can diagnose antibody-mediated rejection without C4d, then what is the importance of C4d? Then it's not important to do C4d. This is an ABMR. No. I want you to remember that since we've known C4d, I want you to look at the amounts of publication since we knew C4d all through the 10 years, and that all of these C4d studies have shown that C4d staining in the peritubular capillaries, whether by immunofluorescence or IHC, has a very high, more than 90% specificity for the presence of DSA if positive. We've always known this. We've always known this information. And we've always known that the C4d score would increase with class 2 DSA. And as I said, that C4d is fluctuant with time in up to 60% of cases. So in class 2 DSA, you would have more of a C4d score. So shall we still perform C4d routine on our transplant biopsies? The answer is yes. It is specific, but not highly sensitive, but it's highly specific. It's more than 95% specific. If you have C4d, you have DSA, but it's not a very sensitive marker. So reliable, and we don't actually still have that much reliable diagnostic features of C4d-negative antibody mediated rejection. They are not, the diagnostic features are not really that much reliable when we don't have C4d. And so accordingly, 2017, before 2017, we required all three features. We required evidence of tissue injury, we required tissue evidence of antibodies in the tissue, which is C4d or endothelial transcripts or microvascular inflammation, and we required DSA in serology to diagnose antibody-mediated rejection. But because it just doesn't make sense. We know if we have C4d positive, then we have DSA. And we all know the DSA detection might not be feasible everywhere. So in 2015, it was agreed that C4d staining by IF2 or 3 and any C4d staining on paraffin sections should be regarded as sufficient for the diagnosis of antibody-mediated rejection. In the presence of MVI, if we have microvascular inflammation, regardless of we can detect DSA or not. I hope this is clear because this makes a lot of problems. I'm not going to discuss DSA, but I'm sure you all know that we have around 30% false negative results in DSA, and we also have false positive results. And as I've said, and I'm still saying, and this comes to everything, C4d, all tests has fallacies. These are all tests. We have always to remember this. But more tests are, there are some tests which are easier to validate and have less error, a margin of error than other tests. C4d is a very easy marker. It's present in the tissue. It's highly reproducible. There is no problem in its interpretation or its staining, except of course for some points, but it is basically for pathologists. However, this is why it is sufficient for diagnosis. So we don't have to have serological evidence of DSA if you have C4d. Still, if you have the feasibility to do DSA, you have to do it because it helps, of course, that you can titrate the activity of the disease and the response of the treatment of the patient by the DSA levels. So it's always good to have a baseline DSA, even if you're C4d positive, but you don't require it for diagnosis if you have C4d positivity. This is C4d and peritubular capillaritis. As I said, again, it's peritubular in peritubular capillaries. This is C4d without significant peritubular capillaries in an early post-transplant case. This was basically actually a case of an acute tubular injury. So if it's an acute tubular injury which with C4d positivity, then this is antibody-mediated rejection. Otherwise, it's not an ABMR. So let's just discuss briefly on the entity and the classification, which is C4d staining without evidence of rejection. And now this is a very unique entity, I have to say. And in this entity, all features must be present for diagnosis. This entity was basically designed for ABO incompatible grafts. Because in ABO incompatible grafts, you can have C4d staining and it's not pathological. They do not, or this is what we know till now, that they do not appear to be injuries to the graft and that they can represent accommodation. This is only in ABO incompatible grafts. If you do not transplant ABO incompatible grafts, any C4d is a reason for worry. So this C4d staining without evidence of rejection is mainly for ABO incompatible, but if we have anti-HLA antibodies, these lesions, even if you have no evidence of rejection, may progress to chronic antibody-mediated rejection. We still need more outcome data. I'm one of the people who would not consider the presence of C4d in an anti-HLA antibody transplant, except that it's pathological, and there has to be a reason why it's there. Because if it's there, it means you have antibodies, and why do we have antibodies in the kidney? So this means you have something wrong going on. Okay, I just want to touch, it's not within the histological criteria of the classification, but I want to allude to it because we do see it. It's not a common finding, but it's there, and we do have a good percentage of patients which present with this lesion. This is de novo collapsing glomerulopathy in renal allografts. Now, this collapsing glomerulopathy in renal allograft, if we're not considering here a recurrent collapsing FSGS. This is a de novo collapsing, just simply collapsing glomerulopathy. And we know now that we can have collapsing glomerulopathy in severe vascular disease. We've already discussed it in diabetics, and we see it in renal allografts, in transplant biopsies. What's the differential diagnosis? The differential diagnosis is that when you get a severe vascular insult, so when they were first described, they were described again as a drug toxicity, as an effect of CNI, both cyclosporin and tacrolimus. And the first series of patients, 100% of them were calcineurin inhibitors. They had very poor prognosis, 100% graft loss in less than 2 years. But de novo or collapsing glomerulopathy can also be a manifestation of severe antibody-mediated rejection, and we do see it. So again, this is one of the lesions which can, glomerular lesion, which overlap with CNI toxicity and with ABMR. Funny enough, we see it more in late type of ABMR, so it's usually always related to antibody-mediated rejection rather than CNI toxicity. You can see in this glomerulus, this patient already had transplant glomerulopathy, and I had, of course, a microvascular inflammation, and you can see he had collapsing glomerulopathy also as well. So this patient was antibody-mediated rejection. Just that you would know when you see it in a pathology report, or that when you read it everywhere, that this lesion does not mean that the patient has recurrent FSGS, but this lesion could be related to antibody-mediated rejection as well as to severe CNI toxicity. Okay, so based on all of this information, we've came to recognize that we have two major phenotypes of antibody-mediated rejection. So when we come to discuss antibody-mediated rejection, we cannot consider it that it's a single type. We actually have two phenotypes of ABMR, type 1 and type 2. Type 1 is persistence, is the one which is related to persistent or rebound of pre-existing donor-specific antibodies. So this is the one which occurs in sensitized patients, patients which are already high risk or sensitized patients. So either they are transplanted with their persistent DSA, or they were desensitized, but there is a rebound of this pre-existing DSA. This is the type which we all know about. This is the type which develops early post-transplantation, but it can also occur anytime post-transplant because this rebound can happen at any time. And this is the one which presents with acute decline in function. So this is the one, the patient which is going to come with rapidly rising serum creatinine. On the other hand, we have type 2. Now, this is the one which is associated with de novo DSA. It's mostly in relation to non-adherence and non-compliance of the patient. It occurs usually late post-transplant, but can occur as early as 3 months post-transplantation. So late does not mean years. Late means months. We see it as early as 3 months post-transplant. And this type presents with a slow progressive course. In relation to morphology, type 1 is the one which usually will have the active lesions, while type 2 is the one usually associated with evidence of chronicity. So this is the one usually where you can have transplant glomerulopathy, peritubular capillary multi-layering, and so on. So again, this is type 1. You're going to have transplant glomerulitis or thrombotic microangiopathy. While in type 2, you're going to have transplant, more common, you're going to have transplant glomerulopathy. In type 1, you're more liable to have a transmural arteritis, while in type 2, you're more liable to have a transplant arteriopathy with all the leukocytes in the blood vessels. So in type 2, there are more tendency to have more chronic changes in the biopsy. What about C4d? Is it different? Yes. It's different also according to the sensitization of the patient. If we have a non-highly sensitized patient, which is most of our patients, in type 1, it's mostly C4d positive. And I would like to say always C4d positive. And I know this is not what's written in the BANF, but it's always C4d positive. And if the early ABMRs are always C4d positive. And if the C4d is negative, there is a reason why the C4d is negative. It might not be there yet. And we do have more than one biopsy, and it's not only me, also with other renal pathologists, this is also a common observation, that you can have a biopsy day +2 or day +3, where it's an ABMR and the C4d is negative, and then when they have the follow-up biopsy in day +7 or day +10, the C4d is all over the place, just 1 week later. So these type 1 ABMRs are always C4d positive, because please be very, very, very careful for diagnosing of ABMR in these early patients when the C4d is negative, except if we know why it's negative. If you gave your patient already significant anti-rejection treatment, if it's a minimal biopsy, and so on. In type 2, if it's a non-highly sensitized patient, it could be positive or negative. And I'm going to show you some data. In highly sensitized patients, on the other hand, usually the C4d is positive. It doesn't make a difference whether it's type 1 or type 2. You usually get C4d positivity. What about DSA? Is it different? Yes. Again, in non-highly sensitized patients, which are most of our population, type 1 is usually associated with DSA against HLA class 1 and or class 2, while type 2 is usually associated with DSA against anti-class 2 DSA alone. So in type 2, with these de novo DSA are usually against anti-class 2. Again, if it's highly sensitized patients, there is no apparent association between the DSA. You can get it HLA class 1 or class 2 in both types. There is no really difference. Of course, you can get type 1 also in, class 1 in type 2 ABMR, but the commonest that you detect the DSA against anti-class 2. I'll show you some figures of a study of our own, which is currently under publication. This is our Egyptian population. And our study aimed to identify the prevalence of antibody-mediated rejection phenotypes in our renal allograft biopsies. So we looked at our renal allograft biopsies from 2013 to 2017 at Path Lab, and cases diagnosed as ABMR were classified according to time post-transplant into type 1, which is before the first year, and type 2, which is more than 1 year, which is the consensus definition of or the time span of these two types. And we have compared morphological features related to antibody-mediated rejection in each type. We used microvascular inflammation score of 2 or more and the C4d status as evidence of current antibodies, because we did not have enough DSA state for every one. But those where we used MVI alone, we had the DSA data for it. So they were all confirmed ABMR. We compared thrombotic microangiopathy, transplant glomerulopathy, and transplant arteriopathy. So we basically focused on the lesions which has a considerable overlap between ABMR and other types of rejection or other diseases. We've also looked at IFTA and the difference between interstitial fibrosis and tubular atrophy between both types, as well as associated T-cell mediated rejection. Okay, so we had 2,239 renal allograft biopsies from 2013 to 2017, out of which 25% were diagnosed as antibody-mediated rejection. These were around 700 biopsies, which is mainly compliant with the usual prevalence of antibody-mediated rejection. Out of these cases of antibody-mediated rejection, 75% were type 2, actually, not type 1. So you can see this is type 1 out of the total, which I think was 735, and this is type 2 out of the total. So 75% of our antibody-mediated cases, when we consider type 2 only 1 year post-transplant, were actually type 2. This is about the cases glomerulitis in type 1 ABMR. This is a case where the G-score was 3. And this is also peritubular capillaritis in type 1 ABMR. And you can see that in early ABMRs, neutrophils are usually dominant rather than in late ABMRs. When we compare the C4d status and microvascular inflammation between both types of ABMR, the early one and the late one, you can see that in type 1, 80% of the cases were C4d positive, while in type 2, 60% were C4d positive. So we definitely have more C4d positivity in type 1, but unfortunately also we have a very high percentage of C4d in type 2. Why say unfortunately? Because C4d on its own is a poor prognostic marker. So when you have C4d, you're looking at a poor prognosis. In relation to MVI, in type 1, less than 50% of cases had microvascular inflammation, compared to type 2, where more than 90% of cases had microvascular inflammation. And there was no, as 80% of the MVI score was score 2, and it was mainly glomerulitis, and there was no correlation between the C4d positivity and MV1 in type 1 cases. There is no correlation between the presence of C4d and microvascular inflammation in type 1, while in type 2, all the cases here had an MVI score more than 4, and C4d significantly correlated with the MVI score. So actually in type 1 ABMR, we get to rely more on the presence of C4d because you don't get this significant or florid microvascular inflammation. And the presence of MVI does not correlate with the C4d presence. On the other hand, in type 2, it's the other way around. You have more microvascular inflammation, tendency for higher scores. The mean scores were more than 4, and the C4d significantly correlated with the MVI, with the presence of the MVI score. This is C4d from a case of type 1, and this is C4d from a case of type 2. Now, thrombotic microangiopathy. When it came to look at the TMA, because of the confusion with the drug-induced, the CNI-induced TMA, it was very important to look at TMA in our population, because some nephrologists rush to stop the CNI once they have a diagnosis of TMA. And be careful, because actually TMA in our population is much more related to antibody-mediated rejection rather than CNI toxicity. So you can see that in type 1, we had around 50% of the cases presented with as thrombotic microangiopathy of antibody-mediated rejection, and 81% of them were C4d positive with statistical significance. While in type 2, we had only 20% of the cases which were TMA. So you can still see TMA very much late post-transplant if you have a type 2 antibody-mediated rejection. So as they were much less in percentage in type 2. So thrombotic microangiopathy has a more likely tendency to be related to ABMR rather than CNI toxicity. What about transplant glomerulopathy? As expected, we had only 1.4% of cases of TG in type 1, but we had 1%. That means we had some cases we've seen transplant glomerulopathy in less than 1 year, while in type 2, almost 50% of cases had transplant glomerulopathy, and it showed a statistically significant correlation with C4d positivity as well. And most cases had a CG score of 2 and a G score of 1. So almost all of them had some form of activity with the glomerulitis score. In relation to transplant arteriopathy, and since this is a lesion which basically overlaps with T-cell mediated, we have the TA and its association with transplant glomerulopathy, and we found that it was associated in around 30% of cases, and there was no statistical significant correlation with the staining of the C4d and MVI for any of the cases where we had, this is in type 2, 50% of cases in type 2 had a transplant arteriopathy, where only we had transplant arteriopathy in 10% of the cases in type 1, and probably these lesions were just healing lesions of enthemal arthritis or so. Associated T-cell mediated rejection, we had up to 25% of cases in type 1 ABMR had associated T-cell mediated rejection versus 15% in type 2, and there was no statistical significance. Most of cases of type 1 had V-lesions. So most of the cases of the associated T-cell mediated rejection in relation to type 1 ABMR were actually V-lesions in this case, while most of cases of type 2 were within borderline category. So as you can see in our studies, we've also seen that, of course, IFTA was significantly more in type 2. 99% of cases in type 2 had some form of interstitial fibrosis and tubular atrophy. So in our population and in our study and in our Egyptian transplant biopsies, we see that type 2 was much more prevalent than type 1. We know that type 2 is mainly related to non-compliance for a medication. So this could be related to young age, to socioeconomic status, and so on. And as you can see, we had more pronounced chronic changes in relation to type 2 than type 1 in our population. Okay. Are you confused or not yet?
Okay, Dr. Wesam.
This is a simple approach I have made just to try to make things not so gloomy, that how do we approach if we are considering ABMR? So if we have a patient with clinical impairment and you take a biopsy, and then this biopsy has tissue injury, which says that you can have an antibody-mediated rejection. What is the second step? The second step is that I look for evidence of antibodies. What would be easier, quicker, and cheaper is to do C4d on the biopsy. If your C4d is positive, hooray, then you have an antibody-mediated rejection. Story is resolved. And preferably, you have some microvascular inflammation with it. Okay, whether a G or a PTC. But what if the C4d is negative? If the C4d is negative, then I need to go back to the MVI and have a score together more than 2. So PTC3 and G0 will work. G1 and PTC1 will work. G0 and PTC2 is okay. G2 and PTC0 is fine. Any combination of these scores, as long as I don't have T-cell mediated rejection with it. So G and PTC score more than or equal to is evidence of current antibodies. But it's not enough. In this scenario, we need to look for DSA. If we have DSA positive, then this is antibody-mediated rejection. This is trying to simplify it as much as possible. So this is the practical approach, and this is what all of us actually do. And this is why we recommend for speed and time, if it's feasible, both economically and technically, to have DSA, then withdraw the DSA sample at the time of the biopsy. If not, and if you want to be more cost oriented, then you can wait for the C4d, and then you can draw the sample and wait and then not send it to the lab or whatever. But this is the best way to work up the biopsies. So in BANF ABMR diagnostic criteria, or the diagnostic criteria for antibody-mediated rejection, we actually rotate around this triangle where we have histology, immunohistology, serology, and at one end DSA and the other end C4d. What if we have a situation where we have a combination of all of these, but the data remain equivocal for the diagnosis of antibody-mediated rejection? Then what are we going to do within this scenario? What's the solution? Like what? Like when we have a G and a PTC score, which is more than 2. We've just said that this is evidence of current antibody activity. But we came to look for the antibodies and they are not there. The biopsy is C4d negative and there are no detectable DSAs. Then what is this? Are these non-HLA antibodies? Maybe. We recommend that in this scenario, you test for non-HLA antibodies, although we don't really know the actual pathogenesis for non-HLA antibodies. And I don't want to overload the non-HLA antibodies with everything that we just don't know or we can't explain and just come up with the easy solution that this is a non-HLA antibodies, because these are extremely rare and we don't know their pathogenesis. But this situation occurs to have a significant MVI, microvascular inflammation, but no evidence of antibodies. Okay, what is the other way around? What if I have evidence of antibodies, but no histological evidence of rejection in an anti-HLA or in an ABO compatible transplant? What if I have C4d positive and I have circulating DSA, but I have no histological evidence of rejection? What am I going to do with this biopsy as well? How am I going to label it? I don't have any tissue injury which is related to rejection. And what if it's an ABO incompatible allograft which has microvascular inflammation and I cannot count on its C4d, because we've already agreed that in ABO incompatible allografts, we have C4d positivity. But if these biopsies has MVI as well, then now what are we going to do? How are we going to know whether these patients have ABMR or not? So we do have situations where when we come to apply the diagnostic criteria for ABMR, it just doesn't work. We still cannot reach a diagnosis whether these patients have antibody-mediated rejection or not. And this is where molecular studies could have a role. This is Phil Halloran, and of course, Phil is one of the pioneers in this arena, and they are the ones who were the first group ever to describe the ENDATs and the molecular studies which are related to transplants. And we study molecules to know mechanisms, to develop new tests, to have international standardization, and to be able to recalibrate our conventional tests according to these molecules, and if they can help to guide and monitor response to therapies. And of course, they empower clinical trials so much. So gene transcripts and its products in clinical applications. We have numerous studies which come up with potential candidate genes in order to predict rejection, graft outcome, etc. But are these feasible? Probably not. Are they reproducible? The answer is no. Can this dream become real? Yes, we do hope so, definitely one day. And can we implement them in our routine clinical practice? So far, no, but maybe for the molecular microscope. And I'm going to tell you what is the molecular microscope. Now, this is, I don't want you to read it because it's basically unreadable, but this is a set of genes from all the numerous studies which are related to ABMR. And some of them are related to T-cell mediated rejection. Just to give you an idea about the number of genes we can be discussing. This, of course, have been, this is basically the prime gene list studies in kidney transplantation, which is with its related diagnoses, what is related to antibodies, T-cell mediated, recurrent disease, viral nephropathies, blah, 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 and all of these lesions. However, in 2017, there were two sets or two tests of a molecular tests which have been promising or which carry a promise that they can be reproducible later on to be used within clinical practice or basically the pathology practice, because these are biopsy-based or tissue-based molecular tests. They are basically the DSAST, the donor-specific antibody-specific transcripts, as well as molecular classifiers. And it's recommended that these are used in the situations we have discussed. When I have a mild MVI and the C4d is negative, but the DSA is positive. Now what? So now I have microvascular inflammation, but it's 1, it's not 2. So I cannot consider it evidence of antibodies. And my C4d is negative, but the patient has DSA. Shall I call this antibody-mediated rejection or not? And all the others that we have described, or you can have severe microvascular inflammation with no evidence of antibodies at all, or vice versa. And also more important, it can help with the lesions we've discussed last time in T-cell mediated rejection, whether we want to know that this inflammation is related to T-cell mediated rejection, or as we're going to see tomorrow, is it related to viral nephropathy, or it's not a rejection process at all? What about these borderline infiltrates, and so on? So increased expression of gene transcripts or classifiers in the biopsy tissue strongly associated with antibody-mediated rejection can be used as a marker for antibody-mediated rejection if thoroughly validated. And I'm not going to tell you about the validation process because it can take all night long. So if it can be thoroughly validated, that means that only very few centers in the world can actually come up or perform these tests on routine base so far. In all cases, they're not supposed to be on routine base. They are also only supposed to be used in problematic biopsies or in problematic patients. So as you can see, I'll sum up that we still have a lot of problems. We still have a lot of confusions with most of the lesions, but we do our best to know where we are around. We need to rely on solid data, the data that we've been reproducible and we've known for years, and know that these are the solid ones for the diagnosis. And I'll leave you that at the end of the day, the predictors of outcome in antibody-mediated rejection are the same. They are the presence of interstitial fibrosis and tubular atrophy. Time post-transplant is important. The early ones are usually responsive. They're usually treated, and patients recover, while the late ones have very, very poor prognosis, unfortunately, and poor response to therapy. Transplant glomerulopathy on its own is a poor prognostic factor, although there was a recent study 2 years, I think 2 years ago, by Mark Haas, and their study have had a good prognosis in patients with transplant glomerulopathy, and they've alluded this that because in their center in Los Angeles, they actually treat patients with transplant glomerulopathy with anti-rejection treatment aggressively. And so in this study, in this specific study by Mark Haas, the prognosis for transplant glomerulopathy was actually good. And of course, C4d, I've just said, C4d on its own is a poor prognostic marker. And the presence of T-cell mediated rejection as well appears to predispose to no-for-DSA on its own. Okay, thank you, and I'm ready if you have questions.
Thank you very much, Professor Wesam, for this very nice presentation. I agree with you that there are still some uncertainties, and I like the sector of molecular microscopy. It is still needs validation, and combining both clinical expertise and transplant pathologist smartness is of paramount importance. Through the years, we learned that C4d is the fourth step of antibody. So we like to know C4d for all transplant cases if we have any morphology that may denote antibody-mediated rejection. I like your statement that acute tubular injury may be explained by a lot and a myriad of causes, including because this is a kidney, pre-renal, renal, post-renal, so we shouldn't forget all these points. Thrombotic microangiopathy is not necessarily to be a calcium inhibitor, but maybe one of the phenotypes of antibody-mediated rejection. I want to ask you two points. Do you follow revised glomerulitis? Because you mentioned during your presentation that you respect glomerulitis if there is some occlusion or near occlusion of the capillaries. And this is the criteria of revised glomerulitis, or use just simply presence of inflammatory cell within the glomerular capillaries.
No, we use the criteria of the revised glomerulitis because it makes sense.
Yes.
Of glomeruli are capillaries and blood filters through the capillaries. So it's okay to find some passing circulating inflammatory cells. Not every neutrophil or lymphocyte I'm going to detect within a glomerulus. I'm going to call it with a glomerulus. I need, with all the rejection, you need evidence that this cell is doing damage. So lymphocytes in the interstitium alone is not enough. You have to have tubulitis. So this is an aggressive cell. Lymphocytes in the lumen of arteries is not enough. They have to cross the border of the endothelium. Then they are aggressive. Lymphocytes within the capillary lumina of the glomeruli are innocent. Unless you have endothelial cell injury, then these cells are also aggressive. So this is it. We also look for evidence that these cells are actually causing damage. That they are not just there.
Does it mean that the revised glomerulitis definitions were validated? Because
yes,
it was still investigational after BAMF 2017.
Yes, no, they were validated and most of us use it.
Okay. Yes, okay. Okay, go ahead, Professor.
Because it made more sense to us.
Okay, thank you very much.
It made it more reproducible. It made the glomerulitis score more reproducible.
The last point from we faced a case with accelerated rejection a few days after transplantation, and the clue for diagnosis was immunohistochemical staining for CD3 and CD20. The old cells were harboring CD20, but as well as CD3. So by this combination, we know that it is T-cell mediated, not antibody mediated, although it is full of CD20. And because of the presence of CD20, it responded well to rituximab. Do you recommend doing the immune histochemistry for subtypes of T-cell, or is there any clue for this?
Well, there have been some talk about the B cells, the importance of B cells, whether the CD20. We know that T cells are CD3. And
Yes.
there have been some talk back, I think in 2015, if I remember right, maybe 2013, about the B cells, the importance of B cells in allografts, but this have never been actually followed up. We didn't, the evidence in the literature was not convincing. So we don't know. I would rather do CD68. Yeah, I do. And CD3 also helps in detecting if you don't see tubulitis. But if I don't see cells actually in the biopsy under light microscopy, then I would just do a CD68 because these are the ones that you don't see by light microscopy. I'm not going to do phenotyping of the T cells. It helps though, also to be very honest, it helps if you're considering a viral infection, especially with the EBV.
And this case was published by Dr. Ahmed Al and other colleagues that doing this phenotypes of the inflammatory cells can pick our attention toward the rituximab for treating, because some of CD17 T cells also for CD20 as well.
Yes. So
okay.
You get an between both. That's
Professor Halawa?
Yeah, add to you as well, CD19 as well is a mirror image of CD20. So actually, if you don't mind, I have too many comments.
You're writing a lot.
Yeah, absolutely. Will you leave me to the end? because, you know, other colleagues, you know, asking questions here. Is
So,
it all right?
Yes, of course, please.
how confident one could be that C4d presence mean that serum DSA is the cause of antibody mediated rejection? As I mentioned, the presence of C4d in tissues means the antibody was there, because the presence of C4d means activation of complement, and the presence of C4d is just 40 steps of antibody, because we may do serological testing and we find false negative results of this assay. So, and I think this was the advantage of BAMF 2017. C4d is very nice, plus morphological damage, it is okay, sufficient for diagnosis and not suggestive for diagnosis. What's your opinion, Professor Sam?
You can be 100% confident.
Yeah, okay. So we agree about this point.
C4d, yes, if you have C4d, you have DSA.
Okay.
Full stop.
I think it is clear, and it is one of the best statements in this webinar. I prefer Professor Halawa to proceed to your comments, and if you have any question from your colleagues, it will be fine.
Yeah, I would like just to emphasize on Asadullah, you know, the presence of C4d in addition to tissue injury.
Yes, yes.
Yeah, it indicates the, you know, antibody mediated rejection, whether you can detect antibodies or not.
Yes.
Because antibodies as well wax and wanes and could be absorbed on the graft. So you could have low DSA, you know, especially if you're transplanting highly sensile, because being absorbed on the graft. So the level does not indicate that, you know, a low level does not indicate that antibodies are not involved. Just to start
and
with,
excuse me, Professor Halawa, sometimes there is a great problem. We can have a very high level of DSA, but the antibody is against the common epitopes. If it is against the common epitopes, this means the epitope is present on many HLA antigen on the beads. The antibody will be distributed all over the antigens on the bead, and this will give negative results. So sometimes antibody, the problem is in the test itself.
All right, okay, sensitivity with the test. Yes, yeah. So to start with, actually, regarding type 2, which is de novo DSA, which is, we used to call it, you know, de novo DSA, which is a type 2. Actually, you know, 15 to 25% of patients, transplant patients, they will develop de novo DSA at some stage.
True.
But you'll be surprised, not necessarily complement fixing, and there is no evidence of graft damage. Will you biopsy this kidney and react on DSA in spite of lack of clinical evidence of tissue damage?
Well, there have been recent literature about protocol where they use protocol biopsies in these patients, actually. And yes, as you said, around 15 to 25% of patients have developed de novo DSA, whether donor specific or non-donor specific, because also this makes a difference, whether these DSA are donor specific or non-donor specific. However, there were some centers where they used protocol biopsies. I haven't seen anyone have biopsied these patients for indication, as long as there is no evidence of any form of impairment and that the grafts are stable. They were all protocol biopsies, and most protocol biopsies of these patients actually did show findings.
Yeah.
If you allow me,
even in the non-donor specific antibodies.
If you allow me, Professor Halawa, for this point, if I follow up a patient and then I find positive DSA, de novo DSA, while the graft is quiescent, no impairment, at least I should satisfy the level of immune suppressive drugs. And in this case, I will not accept low marginal tacrolimus level. So tacrolimus level should be increased above 6 nanogram per ml. So we take the presence of DSA as a clue to optimize immune suppression and to educate the patient to be adherent to the treatment. And you can find some debate about to do biopsy or not. So it is a debatable issue. But the most important is to enhance and increase the level of immune suppression.
Of course. Yeah, I agree with you, actually. And actually, on the, to make, to add more confusion, sometimes it's not associated with proteinuria. So no evidence even of proteinuria as well. Because, there was a debate with some of my colleagues who are interested to biopsy these kidneys, there's no evidence of clinical evidence of damage. There is no proteinuria. What to subject the patient to a risk? Of course, we should.
Well, you can, as I said, you can consider it a protocol biopsy, and then again, you cannot really generalize. I mean, if it's a patient whom I know that it is a medium to high, low to medium risk, and then it develops the de novo DSA, then you follow up usually with the DSA and see the titer of the DSA, and if it's really going up, then you might consider it, and then you can call it a protocol biopsy. This would be completely different from a patient with which was a high, or who was already high risk, and supposedly you did not have, and you need to consider that these de novo DSAs are rebound. For example, I once had a scenario like this in a second transplant patient, and the patient was following up with the DSA. He was already a second transplant, and we've known he lost his first graft also to ABMR. And once he had DSA, the nephrologist biopsied him. And he did have evidence of tissue injury, although he had absolutely no clinical impairment. So you can individualize it, and it's preferable, what everybody agrees upon. If these DSA are persistent and the titer is increasing, then you will need to have a protocol biopsy, because bear in mind that by the time the function is going to be affected, it's going to be too late. Yes.
Yeah, I agree about individualization. Yeah, and because we transplant highly sensitized patients sometimes against positive cross match. And you'd be surprised, we wouldn't do a biopsy unless there is evidence, clinical evidence of graft dysfunction. Because, I kept monitoring this DSA over years. It goes up and down, up and down, up and down. If I left myself, I would be biopsying these patients every 6 months. But they have, all of them have, stable graft function. And even if the biopsy showed evidence of TG, I will do nothing. So I'm thinking of all the time.
The evidence, yes, of TG rather than evidence of
acute.
If you allow me, because there is a very nice study published in Kidney International since 2 years. And for this is a big number of patients treated because of antibody mediated rejection. And for all these patients, there were a biopsy and a serology before and 3 months after treating of antibody mediated rejection. Persistence of anti-HLA antibodies, especially if the C1q positive in the blood, plus the presence of transplanted glomerulopathy in the tissue, predict the poorer prognosis of the graft. So for my mind, if I have a positive DSA, it is a call for optimizing immune suppression. This is at least to be done.
Yeah. And it's also why we are getting back to protocol biopsies in highly sensitized patients.
Okay.
That you at least need to know, even if you need to know what's going on with your patient.
I'm not debating with Professor Halawa because I know his school. His school is not to do protocol biopsy, but for my mind, it's surveillance biopsy plus serial monitoring of the DSA is of paramount importance for those patients.
Surveillance biopsy, yes. This have been the recommendation of all we're talking highly sensitized.
Yes, specifically for this. Yes,
it's acceptable, a well-respected practice, and you discover that one size does not fit all. Yeah. Okay. The second thing I would like to comment, and even TG as well. You kindly mentioned that TG as well may not be associated with C4d staining. Yes, and even not associated with DSA as well. 50% of TG not associated, in spite of being chronic damage, still no DSA. So we rely mainly on a double contour and the morphological evidence.
No. This sentence means that don't interpret transplant glomerulopathy, it's always chronic ABMR. This is what it means. That it can be a chronic TCMR, that it can be a chronic glomerulitis, that it can be a heritage of chronic thrombotic microangiopathy. So don't equalize that whenever you hear transplant glomerulopathy, oh, it's a chronic active ABMR. But let me be more clear. In 80%, it is chronic active ABMR. But you still have 20% of your patients where you should consider other type of diagnoses when your C4d is negative, when you don't have
ESNT.
Yes. So it's not always, because this does not equal this.
Maybe because related to hepatitis C virus infection. So hepatitis C is well known.
This is what the literature, this is what the literature says. I don't know whether you and Mansoura have a specific experience with this, but I haven't noticed that much in our patients. I have to say.
I think your statement is clear. Transplant glomerulopathy alone is not sufficient to say chronic antibody mediated rejection. I should have another criteria.
The other features. You need the other.
Yes. Professor Halawa.
So C4d staining also can happen without rejection, and even can happen in the native kidney. We transplant elderly cadaveric kidneys, and sometimes you'll find, on the protocol biopsy, which is implantation biopsy, positive for C4d staining. So I would like to highlight that it's not necessarily all related to a footprint of antibodies, but it could be entirely non-specific, like this immune complex disease in native kidney, aged kidney, in diabetes. So you find actually a lot of cases report about the C4d staining in various non-immunological insults to the kidney.
I have to say, yes, I totally agree.
Yeah.
And we're using C4d, let me be clear. And we're using C4d a lot now in native biopsies, but not peritubular capillary staining.
Yes, of course, yes.
Yes. So this is the difference. That's why we consider the peritubular capillary staining is transplant specific. This is why this is the only staining I call C4d positive, which is related to a circulating antibodies. But in glomeruli or anywhere else, of course, it can be related to a lot of things. But yes, people who do regular protocol biopsies as well do see sometimes C4d without evidence of rejection. And we've included this as one of the scenarios, which we don't know yet. What is this?
And I think it is a separate entity in the BAMF where we find C4d only, just C4d. And I would like to add a point.
It is in the BAMF included within the antibody mediated rejection category.
And it should be, excuse me, Professor Halawa, it should be also linear, because granular C4d may be found in the lupus and others. So it should be linear and the peritubular capillaries as shown elegantly by Professor Wesam during the presentation.
Yeah.
Yes.
The C4d staining, as well as you mentioned, is already there in APO compatible with transplant APO compatible kidneys, and it could be a sign of adaptation. Yes. So even with highly sensitized, patient as well, and the presence of C4d staining, because the interpretation of the DSA is quite difficult and highly sensitized. You don't know what's happening in spite of the level up and down. But we rely on
and even as we said, even in ABO incompatible, this is what we think so far.
Yeah, absolutely, yes, yeah.
So when we have evidence of rejection, then we don't know what to do. If you have evidence of rejection and you have this C4d positive, which is related that it's an ABO incompatible allograft, then what? Does this patient is rejecting or not?
Yeah, regarding the non-natural antibodies, like angiotensin receptor antibody and receptor antibodies, actually they have different presentations. Sometimes they present with severe hypertension, and C4d staining is positive. There is evidence of graft dysfunction. DCA negative. So we treated as the same, but it was aggressive immunosuppression, ATG for that,
they are known to be more aggressive. Yeah.
Absolutely, yes, yeah. And also the non-HLA antibodies can cause positive cross-match. We transplanted a lot of patients with against positive cross-match to non-HLA antibodies. Again, augmentation of immunosuppression. Yes, rituximab and chronic active or chronic inactive rejection. We tried in few cases, we give 1 dose of rituximab for those patients. They improved, but we lost the follow-up. We don't know what's happened to them afterwards. We can see proteinuria becomes less, and there's evidence of improvement, but eventually, we lost the follow-up for a while till they landed back on dialysis. Have you got any evidence suggestive of efficacy of rituximab in these cases?
Well, I cannot talk about efficacy of a specific treatment, but let me tell you about our experience in treatment of these cases in general. And as you say, some have taken Rituximab and plasmapheresis. We had no time today to show the cases, but I'm going to show you the cases tomorrow. Okay. Now, what happens with type 2 and these patients, especially these patients with TG, and we have more than one patient with this scenario, is that yes, as you say, these patients respond. The proteinuria becomes less, their creatinine is less, they improve. And then I have follow-up biopsies for some patients, which are yearly biopsies, and you swear that you're looking at the same biopsy with the one you have seen the last year.
No change.
What happens? Yes, no change, which is in itself is a good achievement.
Yeah, not getting worse. Yes,
they're not getting worse. And this is what I meant when I said consider ABMR as a chronic antibody disease. You have flares of antibodies. Your patient is going to come with proteinuria and with a rise in the serum creatinine. If you're going to control this flare, go back to a baseline if you want of a DSA. And then this patient is going to continue. You're going to prevent further damage till the second flare of the antibodies. So you're actually prolonging the time of the graft with the treatment. If you left them untreated, what happens is that they're going to be, before the year is over, on dialysis. So the target with these patients is that you preserve the graft as much as you can. And yes,
yeah.
I have seen.
But from our experience, Professor Halawa, if we have active antibody-mediated rejection, the standard of treatment is IV-IgG and plasma exchange, and we may add rituximab for these cases.
And this is acute.
Yeah, but for chronic, it is of no value at all. Rituximab doesn't add anything to the course of chronic antibody-mediated rejection. And the most important in the decision, the most important point in the decision making, we should look at individual cases, because if you have a patient with baseline creatinine 1.5, it is completely different from a patient with baseline creatinine 3 milligram per deciliter. So we should individualize our treatment. And even though we learned that rituximab adds nothing to the course of chronic antibody-mediated rejection. And in some cases, as I mentioned, if the basal creatinine is preserved, we may treat the patient with IV-IgG and the plasma exchange.
No, but that with the chronic is different,
yes.
Professor Hussain, because rituximab might help. And there is some case report, because when we did this based on case reports. I know case report
yes.
very low in terms of hierarchy of evidence. But as Professor Wesam said, we're losing the kidney. So, let us do something. Especially
if you allow me, Professor Halawa, in case reports, some case reports, few case reports showed some success, but randomized controlled trials and systematic review showed no value of rituximab in treating chronic antibody-mediated rejection.
Okay, let me resolve this debate if you allow me.
Sure.
Okay, well, first also I don't know if patients having Ritux alone. Usually these patients have a combination of Ritux and plasmapheresis at least, and probably some IV-IgG. In relation to randomized control trials in antibody-mediated rejection, especially in type 2, and I did not get to this within the talk. There wasn't a chance. Be very, very careful on when you come to interpret these data. And I think when we improve our pathology terminology, then all of these randomized control trials are going to go down the bin. The problem is that the term chronic active rejection encompasses patients with interstitial fibrosis 10% and patients with interstitial fibrosis 70%.
So different, yes.
Yes, and it doesn't say. And you don't know how much. We have patients, I have cases, and I'm going to show you tomorrow, with transplant glomerulopathy only. There is absolutely nothing else in the kidney. No interstitial fibrosis, excellent blood vessels, nothing. The patient only has a TG, and it's quite active, but it has a TG. How are you going to leave these patients untreated? But we call this patient chronic active antibody-mediated rejection, exactly the same like we call the patient with interstitial fibrosis 50%, with a transplant arteriopathy, with a global sclerosis of 30%, also chronic active ABMR. We call the ones C4d positive as the ones who are C4d negative, and we know that C4d is a poor prognostic outcome.
This is what we do, Professor Wesam. This is what we do.
For purely randomized control trials in ABMR is quite tricky, because this group, as we identify them as pathologists, are quite a heterogeneous group, and this is what we are working on now, starting 2019, to be more specific in the diagnostic terminology in relation to, only in the diagnostic terminology. We didn't change anything in the criteria, but that we need to add to our diagnostic lines what we consider mild, moderate, or marked activity, and mild, moderate, and marked chronicity, instead of lumping all of these cases within the same category of a chronic active ABMR.
I agree with you, Professor Wesam, regarding the diagnostic facilities and diagnosis of the cases. But what I mean is rituximab by itself adds nothing to the treatment of chronic antibody-mediated rejection. And if we decide to treat chronic antibody-mediated rejection, we should treat this case like what we treat active antibody-mediated rejection, IVIG and the plasma exchange. Rituximab adds nothing for chronic, and it may add a little, very little, for active antibody-mediated rejection, as clarified in 2019 working group for position statement of treating antibody-mediated rejection.
You know, hang on a second, because actually in chronic antibody-mediated rejection, they may not have enough DCA to plasmapheresis, so to plasma exchange. So you are, plasmapheresis is just removing what? There's nothing there, already fixed on the graft, so you can't remove it. So, in terms of randomized control trials for rituximab, I haven't seen a quality study talking about rituximab in this trial. All of them are case reports and case series. To be honest, and I feel, one dose, this is what I explained, one dose of rituximab, actually, what they described, 2 doses of rituximab. So 1 dose or 2 doses of rituximab, if you're going to prolong the graft, I agree, there's no evidence. It's not evidence-based. This is, by all means, is not evidence-based. But if you're losing the graft, they are in desperate situation, especially if you have a young patient, 3rd transplant, and medical compromise, you won't transplant him again. So if you prolong the graft, God only knows for how long, but better than landing on dialysis shortly.
This will depend upon the clinical scenario of the case. If
but
you have
fibrosis, which is very important, if the kidney is badly damaged with interstitial fibrosis, tubular atrophy, it's waste of time. Yeah, but if there is, as you mentioned, I wasn't aware of the case she mentioned. Just TG and the rest of the kidney is quite crispy and clean. So I think this case was to think of something else rather than waiting for the kidney to fail.
Also, after combining the clinical scenario of the case, Would you allow me to just to give a chance to Professor Riyad Saeed, because here is his hand, and Dr. Muhammad Saeed. Professor Riyad.
الو
ازيك يا باشا؟ اتفضل.
ازيك يا باشا؟ مساء الخير.
مساء النور.
دكتور وسام. Great talk. It's a long one, but it's great. You sum it up. I have a couple of comments, if you allow me, please.
Please.
I think I'd like to reiterate what Professor Halawa mentioned about de novo DSA in absence of any clinical evidence of allograft dysfunction, i.e. abnormal creatinine, abnormal proteinuria. I think there is no indication for a kidney biopsy as we do just routinely. Surveillance or what you call protocol biopsies, that's something else. That's really one statement.
Okay.
Secondly, concerning the acute kidney injury in allograft, not every acute kidney injury is really rejection. We spend a lot of time talking about it, but we do have some other causes of allograft dysfunction that we should really work our patients thoroughly. I'd like to mention something that Dr. Wesam mentioned about cast nephropathy. Rabamune cast nephropathy that she showed a beautiful slide. In fact, we have a similar patient who's having both combined liver and kidney transplant for oxalosis, and he came with abnormal kidney function. He was Rabamune, a beautiful cast nephropathy. Looks like exactly myeloma. The patient was in his 20s. So we have to consider some other causes of acute allograft dysfunction. And that's really my comment.
100% agreement about the Professor Riyad statements. We agree about these points. And now Dr. Muhammad. You are welcome.
Thank you, Professor Wesam. MashaAllah, very excellent presentation. You made it easy for a very difficult topic. Just quickly, you just till now the renal biopsy is considered the gold standard tool for diagnosing acute rejection or the cause of rising creatinine, but you make it very difficult because you elegantly presented the challenges for interpreting the finding in renal biopsy, and many of the finding in the BANF and in the AMR criteria might not be 100% specific. And in traditional situation, creatinine rising, we did the biopsy, we find the AMR, we already late. And most of this histological finding denote an aggressive advanced lesions which might not be 100% recoverable. And this might explain why we didn't achieve a very good progress in the long term. We achieved very good improvement in the short-term graft survival over 1 year, but still 10, 15, 20 years graft survival is not improving. And I think because we are late in our diagnosis, if we will wait until creatinine increased and then we did the biopsy, we find histological lesions, we are already late. So we have to think about something which might be used early or before we find any change in the biopsy. I agree with Professor Hussein when he mentioned if we find DSAs, C4d, even with absence of histological finding, we have to individualize and upgrade our immunosuppression to increase the FKM. Because if we will wait to the next step, and then we find MVI, we find arthritis, we find fibrin thrombi, we might lose the graft on the long term. The other point you mentioned, I think in this new era of COVID-19, there was a debate about using non-invasive tool to diagnose rejection. And in the ETC just recently, they mentioned peripheral blood sampling for donor-derived cell-free DNA, which might be validated, or they are doing many validation studies to use it in conjunction with the biopsy, or maybe in the future it might be used alone to anticipate rejection or to modify our treatment protocol. So what do you think about this donor-derived cell-free DNA?
Dr. Wesam? Sorry, I unmute. Yes. Yes.
Well, yes, I have read this, and they look to be promising, but they are also in conjunction with the biopsy. And we just have to wait and see. But all over the years, we've gone through a lot of markers and biomarkers, trying to find any other way to get to a diagnosis without the biopsy. And luckily for me, so far you didn't succeed. But an important point is to consider, even in relation to the molecular base, probably we still have a long way, and we will not be able to rely on a single diagnostic test ever. And even in conjunction with the biopsy represents for you an aspect that you don't see, a focal area only of the kidney. With a blood test, you're seeing the reaction on the level of the lymphocytes. So it could be an important added valuable tool, but I think it will always be an added valuable tool.
Let us say for clinical backgrounds, biopsy is still the gold standard. But for research, yes, because in Renal Week, even last year, not this year, they presented a report about a study for repeated DSA and repeated donor-derived free DNA, and it is enough for diagnosis, but it is still for research and not for clinical background. Unfortunately, there is no replacement for kidney biopsy up to this moment.
Why, unfortunately?
Because the other point,
regarding
other point regarding the fallacies in the C4d and the DSAs, C4d negative, C4d positive. Do you think it is not a correlation? It is only a correlation, not causation. Maybe something, a third party that we are not aware, controlling both the antibody and the footprint of C4d. Because there is a theory that it is not.
Is not a fallacy.
I know,
I mean it's not a false negative test. It's a lack of sensitivity, or that the C4d is not there. But in DSA negative, it's either they are also too low to detect, so the test is not sensitive, or it's a false negative test. So it could be a fallacy in the sample. But yes, do we have a third thing going on? Maybe.
Would you please we'll move to Professor Yasser Hamid. Thank you, Dr. Mohammed. Professor Mohammed.
Thank you.
Yes.
Thank you, Professor Wesam, for this highly elegant talk, and thank you all for this highly informative discussion. And especially stressing on the effect, the drugs as differential diagnosis for many of the changes seen in antibody-mediated rejection. And I agree with you that TAC is similar to cyclosporine in inducing TMA. My observation is that we find now many biopsies with TMA. Do anyone have an explanation for this increasing incidence for TMA, especially in the TAC using area?
I don't know, but I think we are just, it's like when you know something, you see it more. We're recognizing it. We're just recognizing it more. You think more, yes. You think that it's been more prevalent, but it might not. Might not be the scenario. And actually, on the other hand, it's the other way around. When our sensitivity for diagnosis of ABMR with the presence of the microvascular inflammation in the C4d negative cases have increased the TMA-related ABMRs much more than the TMA-related drug toxicity ones. So the ones that we diagnose, and so now with the DSA and with the evidence of the injury, even in the setting of C4d negative, we still can't relate the TMA to antibody-mediated rejection. So now, on the contrary, the TMAs are more related to ABMR rather than drug toxicity, but we still see it. So I think it's only a difference in the interpretation.
A very nice large cohort of patients, Professor Yasser, were published 10-year follow-up biopsy for TAC-treated patients, and showed elegantly many pathologies, including transplant glomerulopathy and others related to tacrolimus. And they think why tacrolimus improved short and intermediate term, and the long term is still lagging and lacking. So this is a question. So I can forward this article to you because I think it includes more than 1,000 cases of follow-up biopsy for TAC treating.
Okay, if you please.
Okay.
If you please.
Dr.
Thank you.
شكرا. Dr. Faisal.
Thank you, Prof. Hussein. I enjoyed the talk very much, actually. Wesam did excellent work, and she's always makes things easy. I don't have too many comments, but I will go with what Prof. Halawa and Prof. Hussein, who else have the same comment. Okay, about we cannot take biopsy from each patient. We have to look for the clinical sense as well before taking biopsy. Or if someone presented with high creatinine post-transplant, it is not necessary to rush for biopsy. We have to wait, exclude other things. First, maybe the patient could have some pyelonephritis, some dehydration. We have so many patients admitted with high creatinine post-transplant with dehydration, and we just hydrate them and things are returned back to normal. So we shouldn't rush to the biopsy. Too many patients coming having infection and they treated and returned back to normal without going and put the patient in any hazard to take biopsy from them. But still, if we have doubt about rejection and they have some other parameter, not only high creatinine, maybe something else which can give us clue that the patients have rejection, like anuria, like graft tenderness, like so should go for probably biopsy immediately, but we shouldn't rush for that. This is, I think, two of our colleagues. I go with Prof. Halawa actually, with his recommendation, Hussein. I am a little bit probably because of the age. We are a little bit conservative to be rushed for biopsy.
Or nearly the same age, Professor.
This is what I mentioned. If we have a case, clinical, and putting a differential diagnosis, and if the cause of the graft's function is not clear, this is the place of biopsy. And this is what we do in our work. If we have a patient with watery diarrhea and the renal factor, if I have a patient with septic shock and he is graft, we shouldn't forget the differential diagnosis, because at the end of the day, it is a kidney, pre-renal, renal, and post-renal, what we accustomed to use for all our life in dealing with impaired kidney. So yes, we should put clinical and differential diagnosis, and if the cause is unexplained, biopsy is mandatory to solve the problem. Dr. Yasser Al-Mulla. Shukran, Professor.
Shukran.
Many thanks for the excellent discussion and the healthy comments. One thing to say, and I will not call it a debate, I will call it a healthy discussion, is that there was a trial called Rituximab C4 trial, which is an outstanding trial in 7 UK centers, and it showed no benefit of rituximab at all. As Prof. Hussein said, it's called Rituximab C4 trial. And otherwise, I don't have any other comments to say, but few comments about the TMA. And I'm aware that Prof. Hussein will present a talk about the TMA recently. The mTOR inhibitor can cause TMA. It's not only the CNI. And we saw a couple of cases. And I like the table which shows the differential for the TMA. But one more differential, which is coming more in clinical practice, is CMV viremia can also cause a TMA. And there is an increasing case reports and case series of CMV viremia causing TMA. Otherwise, no extra comment to say. And I'll be looking forward for tomorrow's presentation about the clinical cases. And many thanks for all. And again, this is not a debate. This is a healthy discussion.
Thank you very much. Thank you, Dr. Yes. We agree. And I think now the last comment to Professor Halawa. To close with Professor Halawa.
Yeah, really, thank you very much. Actually,
starting with Professor Halawa and ending with Professor Halawa, because it is Halawa.
Regarding the TMA, actually, you'll be surprised that more than 70 drugs can cause TMA. It's not only immunosuppression. Even penicillin can cause TMA. So we have to be aware that TMA, even drug-induced, not necessarily to be the immunosuppressive drugs, because all these patients taking an awful lot of medications as well on top of that. But of course, you know, we are always frightened of CNI, but it could be being reported with
mTOR inhibitors,
be reported with any antimitotic drugs, be reported with penicillin. You know, so we have to be careful with the word drug-induced, because it could be swapping tacrolimus with CNI with cyclosporin. However, something else is causing it. Just to be minded. I haven't seen it, you know, other drug-induced. Only actually, I've seen it with cyclosporin. I haven't seen it with tacrolimus, but of course, been well reported to be caused by any other medications.
We see thrombotic microangiopathy with different immune suppressive drugs, including calcineurin inhibitors and mTOR inhibitors in few cases in our center. So I think after 2.5 hours, we should say thank you, Professor Wesam, for this very nice, very helpful presentation about the update in the antibody-mediated rejection. We have I cannot express my gratitude for all what you did with us in the subsequent webinars, and we are eager to listen to you tomorrow for the viral-related dysfunction of the graft. And I would like to thank all the attendees, all professors and colleagues from Egypt and different Arab world, Professor Riyad Saeed, Professor Faisal Shaheen, and needless to say, Professor Saeed Khamis, Professor Mohammed Saeed. And this means that these webinars are weighted for refreshment of all of us, and all of us get the benefit to follow Professor Wesam. Thank you very much. Hoping you a nice day and goodbye.
Good night, everyone. Good night.
Thank you, Professor Halawa, and all your colleagues from Liverpool. The video will be uploaded before 10 a.m. tomorrow, inshallah.
Sharp.
Thank you and goodbye. Goodbye. مع ألف سلامة. أسلامة الله.
مع أمان الله. السلام عليكم.